Chapter 23 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 23 Scarlet Fever. Scarlet fever is an acute infectious disease having as its main features a characteristic rash, an inflamed and painful throat, and a high temperature, usually of short duration. One attack of scarlet fever usually confers immunity from further attacks, though this rule has occasional exceptions. It usually occurs before the 10th year, but infants are rarely attacked. The disease is very highly contagious and is looked upon as being probably an infection with some form of Streptococcus. The main sources of contagion are: 1. The patient; 2. The room occupied by the patient and its contents; 3. A third person, nurse or doctor. This mode of contagion must be very rare, and is wholly denied by some authorities. The period of incubation is from 2 to 6 days. The period of invasion is from 12 to 24 hours. The period of eruption is from 4 to 6 days. The period of desquamation is from 3 to 6 weeks. Symptoms: average attack. The onset is sudden, and often accompanied by vomiting. The temperature rises rapidly to 103 or 104 degrees, with the usual symptoms of fever. There is redness of the pharynx and tonsils, and small red spots are seen on the hard palate. The redness of the throat is somewhat characteristic. It is a dark, deep crimson blush, quite uniformly spread over the entire pharynx and both tonsils. The tongue is known as the strawberry tongue, and is very well named. The papillae at the tip of the tongue are swollen, and the resemblance to the rough red surface of a strawberry is very marked. The glands of the neck are invariably swollen and tender. The rash develops in from 12 to 36 hours after the appearance of the first symptoms. It is first seen on the neck and chest and gradually spreads over the entire body. The rash is what is known as a uniform diffuse erythema. On close examination it appears to be made up of countless minute red points. When developed, it gives the impression of an evenly distributed blush, not distorting the countenance as does the rash of measles. Unfortunately, the rash of scarlet fever often varies, both in character, intensity, and distribution, and at times may be almost absent. Such cases, with very slight rash, are often unrecognized and must be one of the important factors in furthering the spread of the disease. The rash lasts from 3 to 7 days, when desquamation sets in. With subsidence of the rash, the temperature gradually drops to normal. Desquamation in scarlet fever is a very long process, lasting from 3 to 6 weeks. Peeling takes place in the form of very fine scales, and is most apparent in those portions of the body where the skin is thickest, i.e., the palms of the hands and the soles of the feet. In these localities desquamation often occurs in large sheets, occasionally an entire cast of the palm of the hand or the sole of the foot being given off. In mild cases, the temperature may not exceed 103 degrees, and lasts from 3 to 5 days. In severe cases, the fever is higher and more continued. There is greater prostration, and all the signs of a severe general infection are marked. Finally, there are the cases of so-called malignant scarlet fever, in which the patient is completely overwhelmed by the intensity of the infection, and death occurs in from 12 to 72 hours. Complications. 1. Acute nephritis. Scarlet fever is one of the most common causes of acute nephritis. The symptoms of this condition are dwelt upon in detail in the proper chapter, but a few words must be said here concerning this dangerous complication. The nurse must remember that the two signs of a beginning nephritis in the course of scarlet fever are: A. Edema. The child has a rather puffy look, especially noticeable in the face. B. Diminution in the amount of urine. Either one or both of these symptoms are of the utmost importance, and demand immediate notification of the physician. The nurse must also bear in mind two things in connection with scarlatinal nephritis. 1. The most severe nephritis may occur as a complication of the mildest attack of scarlet fever. 2. Acute nephritis very frequently occurs during convalescence from scarlet fever. In short, no nurse caring for a case of scarlet fever can lower her vigilance for the signs of a beginning nephritis until she is dismissed from the case. Usually, the patient's condition during the long period of desquamation is so satisfactory that daily visits on the part of the physician are not needful, when he is aided by the watchfulness of a competent and interested nurse. 2. Acute otis media. This is the most frequent complication of scarlet fever, but is not as dangerous as acute nephritis. If the otitis occurs at the height of the disease, there may be no symptoms. If during convalescence, earache and a rise in temperature are characteristic. As a rule, both ears are involved at different times. 3. A membrane inflammation of the larynx may occur, giving rise to symptoms similar to that observed in laryngeal diphtheria (QB). 4. Other infectious diseases, especially diphtheria, may complicate scarlet fever. Prognosis. The outlook in scarlet fever is always serious. The younger the child, the graver the situation. Save for the malignant cases, scarlet fever, in the absence of complications, is not a very fatal disease, but the frequent occurrence of dangerous complications makes it a malady to be dreaded. In mild types of the disease, the mortality is under 5%. In severe types, it may be as high as 50%. Prophylaxis. The following directions for the establishment of quarantine hold good for scarlet fever, measles, diphtheria, varying only in the length of time quarantine is to be maintained. Room quarantine is to be installed at once, and maintained for the time designated by the local board of health, as a rule from 4 to 6 weeks. Nurse and patient are to be isolated in the sick room. When possible, a connecting bath is desirable, and, if practicable, a little diet kitchen should be installed in the bathroom, using a small gasoline or gas stove, so that no article need be sent out of the sick room. In the vast majority of cases of scarlet fever, such conveniences will not be obtainable, and the best possible must then be done. A sheet moistened with bichloride of mercury solution, 1 to 1000, or carbolic acid, 5%, should be hung before the door. In the author's opinion, this procedure has no great value in preventing the dissemination of infectious material, but the striking appearance of the sheet before the door has a wholesome effect upon members of the family inclined to carelessness, and acts admirably as a no admittance sign. All food brought to the sick room should be left at the door, and taken in by the nurse. Before the dishes and other utensils are replaced outside the sick room, they should be allowed to soak for 2 hours in bichloride, 1 to 1000, or carbolic, 5%, solution. All bed linen, towels, gowns, etc., should be similarly treated before being set outside to be washed. Both dishes and bedclothes should not be washed in conjunction with those used by the family. The room should be cleared of all unnecessary furniture, rugs, curtains, etc., and should be frequently cleaned by the nurse by being rubbed with a cloth wet with bichloride, 1 to 1000. The attending physician should have a gown and cap, which he should put on every time he visits the patient. These should be hung on a hook just inside the door. If no gown and cap are available, a very satisfactory gown can be made from a sheet, and a small towel pinned turban fashion makes a thoroughly practical cap. The nurse should have at hand a basin with soap and water, a basin of bichloride solution, and a towel for the physician at his visit. She should also request tongue depressors (wooden ones are the best), so that throat examinations can be easily made, and recourse to the unhygienic spoon become unnecessary. If the nurse will, provide herself with a pocket flashlight, which she will find useful in many ways, she will often greatly aid the physician, who may have left his at home. At the termination of the period of quarantine, the nurse should give her patient a bath in bichloride, 1 to 5000, and wash the hair well with this solution. Following this, the patient should have an ordinary hot bath and put on clothes that have not been in the sick room. The nurse should then take her own bichloride bath, wash her hair, take a hot bath, and also put on clothes that have not been in the sick room. Treatment. We have at our command absolutely no means of shortening or altering the course of scarlet fever, which is wholly a self-limited disease. Treatment is purely symptomatic. Bed, liquid diet during the period of fever, and keeping the bowels well open are the foundation stones for the management of a case of scarlet fever. During the eruption, the patient should be anointed daily with Vaseline or cocoa butter. After the rash has disappeared, daily warm baths with soap and water are frequently used. For very high temperature, cold sponging gives the best results. When toxemia is very severe, stimulation may be necessary according to the discretion of the physician in charge. It is usual to give a gargle or to prescribe some antiseptic with which the throat is to be swabbed. One of the essentials in nursing scarlet fever is eternal watchfulness for complications. During the long and tedious period of desquamation, when the child feels quite well and must still remain isolated, the nurse will have to tax to their uttermost her talents for diverting and amusing her little patient. End of chapter 23. Chapter 24 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 24. Measles. Measles is an epidemic contagious disease and is more widespread than any other eruptive fever. Incubation, i.e., from date of exposure to onset of catarrhal symptoms, from 11 to 14 days. Invasion, i.e., from onset of catarrhal symptoms to the development of the rash, usually 3 to 4 days. Eruption, i.e., duration of the rash, 4 to 6 days. Desquamation, i.e., peeling, 1 to 2 weeks. Etiology. The essential cause is unknown, though it is believed to be some germ as yet not isolated. Only a short exposure is necessary for its communication, and close proximity to the infected individual is not necessary. The disease is highly contagious from the onset of the catarrhal symptoms, and as the patient is not ill and confined to the house at that time, measles is spread on all sides. After the disappearance of the rash and catarrhal symptoms, the communicability rapidly decreases, and during desquamation is but slight. Generally speaking, the duration of the infective period is 3 weeks. Children are usually attacked. Very young infants are not as susceptible to measles as those somewhat older, but in the very young the disease is a serious matter. The vast majority of those having measles are under 12 years of age. One attack usually produces an immunity to measles, but there are many exceptions to this rule, and 2 and even 3 attacks are not very uncommon. Symptoms: average attack. The disease is ushered in with symptoms of a diffuse catarrh of the upper respiratory tract. The patient has a running nose, running eyes, a sore throat with redness of the tonsils and soft palate, a hoarse, harsh cough, and in a day or so, some sputum. The catarrhal process spreads to the bronchial tubes, and bronchitis is present so frequently as to be looked upon as a symptom of measles, and not as a complication. The temperature rises gradually until the appearance of the rash reaches about 104 degrees as a maximum, and lasts in all usually about a week, varying from 5 to 9 days. At first there is some dullness, pain in the back, headache, and general malaise, feelings that accompany any moderate rise of temperature, and that present no characteristic features. Vomiting and diarrhea are rarely seen save in the severer forms. Before the appearance of the rash there is but one sign that will point without question of doubt to measles. The sign is Koplik's spots, bluish gray spots seen against a red background on the mucous membrane of the cheeks and lips. The rash of measles appears, as a rule, on the 4th day of the disease. It is known as a maculopapular rash. It appears first behind the ears, around the neck, and at the roots of the hair, as small dark red spots, not numerous, not elevated, and looking somewhat like flea bites. In 24 hours the macules are numerous, and many have become papules. The rash spreads rapidly to the chest, arms, trunk, and eventually involves the whole body within 36 hours. The papules, which have at first been single, may fuse, and in so doing often assume a crescentric form. At the height of the disease the patient may be so disfigured by the rash as to be unrecognizable. The skin is swollen, there is great itching, the eyes are red and very sensitive to light, and, as a rule, there is a conjunctivitis with the formation of mucopus. Pain on swallowing and swelling of the cervical glands are common. With the fading of the rash the temperature drops gradually, and reaches normal in from 2 to 3 days. Also, with the fading of the rash, desquamation or peeling sets in. This is first noticed on the face and neck, and is in the form of fine, briny scales, never in large patches, as in the case in scarlet fever. As mentioned before, desquamation lasts from 1 to 2 weeks, usually about 10 days. Some cases of measles are so mild that were it not for other cases in the family or immediate neighborhood, they could not be recognized. On the other hand, other cases are so severe that either the patient is overcome by the systemic poison within a few days, or else the whole force of the infection seems to be expended upon the lungs, and the case is more one of bronchopneumonia than measles. Some severe cases have a hemorrhagic rash, others have convulsions and delirium, with all the signs of intense general poisoning. Complications: 1. Bronchopneumonia, frequent and dangerous. The symptoms that will cause the nurse to suspect a bronchopneumonia are: A. Rise in temperature. B. Rise in pulse rate. C. Rise in rate of respiration. D. Increase in cough, and in older children in expectoration. E. Appearance of slight cyanosis in young children, or in the very delicate. 2. Otitis media, also frequent, but not as dangerous as bronchopneumonia. Older children will usually complain of pain in the ear, and thus the nature of the trouble can be suspected. But in very young children and in infants, the nurse must be constantly on guard for some change in her patient that will make her suspect otitis media. In the very young, the following symptoms are suggestive. A. Rise in temperature not traceable to the bowels or lungs. B. Fretful and persistent crying. C. Difficulty in taking the bottle in infants. D. At times evident pain and tenderness in the region of the ear. With such symptoms, the nurse should at once call the physician, who will make the diagnosis by examination of the ear through an ear speculum. Diphtheria and scarlet fever may complicate measles. Kidney complications, nephritis, are rare, as are heart affections. Laryngitis is present in practically every case. When membranous laryngitis occurs, it is caused either by the Diphtheria bacillus or the Streptococcus, and the symptoms are those described under laryngeal diphtheria. Prognosis. The outlook in the better class of private practice is generally good in children over 3 years of age. In those younger, mortality is fairly high. In those over 3, the average mortality is from 4 to 6%, and often it does not reach these figures. In institutions, the picture is reversed, largely because the patients come from the poorer walks of life, are underfed, and have poor resistance. Here measles plays great havoc, in some institutional epidemics the mortality ranging from 15 to 35%. Prophylaxis. Room quarantine is required by law for a variable period depending upon the ruling of the local board of health. As the details for maintaining this quarantine are the same, save in point of time, as for scarlet fever and diphtheria, they have been given but once and will be found in the chapter on scarlet fever. Treatment. Measles is a self-limited disease, and we have no means at our command to shorten or modify it. Treatment is, therefore, wholly symptomatic. The room should be darkened, especially in summer, by means of blinds or green shades, and the electric bulb or lamp covered with a red shade, in order to lessen all possible irritation of the eyes. An initial purge with calomel, followed by a saline or castor oil, is usually given. If the eyes are painful, ice cold cloths frequently give relief, and the mucopus appearing as a result of the conjunctivitis should be wiped away with small bits of old linen moistened in a solution of boric acid. Vaseline may be freely applied to the lids. Vaseline or cocoa butter should be rubbed over the child's entire body in order to allay itching. The diet should at first be liquid. Later in the disease, eggs, toast, cereals, gruels, ice cream, and crackers may be added. After the appearance of the rash, a daily warm bath should be given in addition to the injunction above referred to. The cough will usually need some treatment. Generally, opium in some form is given, either as codeine or heroin combined with an expectorant mixture. In cases of excessively high fever, 105 degrees or over, recourse is usually had to cold sponges with alcohol, 1 part, water 3 parts. With failing heart, stimulation is indicated though there is rarely need for this save in the presence of bronchopneumonia, when the treatment becomes that of the complication rather than that of measles. The eyes must not be subjected to any undue strain for several weeks after measles, and during and after convalescence the child must be carefully watched, and every precaution taken against catching cold, for the mucous membrane of the entire respiratory tract is in a condition of lowered resistance and is particularly susceptible to all manner of infection. If cough continues for any considerable length of time after recovery from measles, the possibility of tuberculosis must be borne in mind, this disease being one of the most frequent sequels of measles. End of chapter 24. Chapter 25 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Ferrard. Chapter 25. Diphtheria. Diphtheria is an acute, infectious, contagious disease characterized by the formation of a gray-white membrane on the tonsils, uvula, and soft palate, and by constitutional symptoms of varying intensity. Etiology. The Klebsiella bacillus, discovered in 1883. Diphtheria is very contagious. Short exposure is all that is necessary for infection to take place, and in addition the disease is spread by carriers, i.e., persons having virulent diphtheria bacilli in their throats, but because of a natural or acquired immunity, not ill with the disease. Symptoms. The incubation period of diphtheria is from 12 hours to 3 days. While diphtheria may occur on any mucous membrane where the bacilli lodge and develop, nose, vagina, stomach, etc., it is very rare to see the disease anywhere save in the pharynx or larynx, and these two forms only will be considered here. 1. Pharyngeal diphtheria. The onset is reasonably sudden, with chilliness, headache, fever, not particularly marked. It is uncommon to see a temperature over 102 degrees. Within 24 hours, the throat becomes sore. At first it is red, but soon spots of gray or dirty white appear on one or both tonsils. These increase in number, unite and spread to the uvula and soft palate. In a fully developed case, the back of the mouth is often seen to present an arch of gray membrane reaching from tonsil to tonsil. The membrane is thick and tenacious, and when pulled off, leaves a raw, bleeding surface. As the disease progresses, prostration becomes more marked, and signs of heart weakness are frequent. The membrane may disappear as a result of treatment, or, in unfavorable cases, may spread to the nose or larynx. Cultures taken from the throat show the presence of diphtheria bacilli in large numbers. The course of diphtheria is variable, lasting from 6 days to 3 weeks, but has been wholly changed since the introduction of treatment by antitoxin. 2. Laryngeal diphtheria. The general symptoms are the same as those of pharyngeal diphtheria, save that, as a rule, prostration is more pronounced. The first local symptom is a hoarse, brassy cough. The voice may be merely husky, or the patient may not be able to speak above a whisper. If the membrane continues to spread over the larynx, dyspnea sets in, due to obstruction to the free passage of air. Cyanosis sets in, slight at first, but in severe cases gradually increasing until the entire face looks dusky. The patient gasps for every breath, The pulse is rapid, small, and weak, and the entire body covered with a cold sweat. In untreated or very virulent cases, the larynx may be entirely filled by the membrane, and death from suffocation result. Complications. 1. Nephritis. Almost a constant occurrence, and due to the action on the kidney of the toxin of the Diphtheria bacillus, usually transitory, not serious, and diagnosed by the urinary findings. 2. Cervical adenitis. The glands of the neck are very frequently involved. They are often swollen and tender. Occasionally they break down and suppurate. 3. Bronchopneumonia. This complication is always serious. The gravity depends upon the age of the patient. If a child, the younger it is, the more serious is the complication, and the severity of the diphtheritic attack. Bronchopneumonia is particularly apt to complicate cases of laryngeal diphtheria. For symptoms of this condition, see chapter on bronchopneumonia. 4. Various paralyses. Very important. Due to a definite toxic action of the diphtheria poison upon the nervous system, many varieties of paralysis may occur, chief among them being A. Palatal paralysis, soft palate, causing a nasal voice. B. Paralysis of any of the eye muscles. C. Paralysis of any of the accessory muscles of respiration. If at all extensive, this is characterized by a peculiar sighing respiration. 5. Heart failure, most important of all. The toxin of the Diphtheria bacillus has a very definite selective action upon the heart muscle, causing a degeneration of the muscle fibers, a toxic myocarditis. Myocarditis is suspected from the rate and quality of the pulse, and from the fact that any physical exertion has a marked effect upon the circulation. Neither extreme of pulse rate is of good omen, for a rapid pulse rate is always cause for alarm, and a slow pulse rate an indication of serious trouble. 6. Vomiting. When this occurs early in the disease, it may be due to the temperature and malaise that accompany any acute infectious disease. When vomiting occurs late in the disease, it is a very important and very dangerous symptom, as it points to beginning degeneration of the vagus nerve. Prognosis. The outlook in diphtheria is always grave, though its course and termination have been so entirely revolutionized by treatment with antitoxin that this factor must always be held in the foreground. The gravity of prognosis and the rate of mortality are in direct proportion to the delay in administering antitoxin. Kossel has shown that when antitoxin is injected on the first sign of the disease, the percentage of recoveries is 100. In this, every hour counts. Out of 2,428 cases reported by Hilbert, the percentage of deaths varied with the day on which antitoxin was administered, as follows. Day of administration. First day, mortality 2.2%. Second day, mortality 7.6%. Third day, 17.1% mortality. Fourth day, 23.8% mortality. Fifth day, 33.9% mortality. Sixth day, 34.1% mortality. After sixth day, 38.2% mortality. Vaughan. The prognosis is always much graver in laryngeal than in pharyngeal cases. Treatment. The treatment of diphtheria can be divided into two classes. 1. General treatment. 2. Specific treatment, i.e., antitoxin. 1. General treatment. A. Prophylactic. The patient is to be isolated as described in the chapter on Scarlet Fever, and quarantine is to be maintained until release is permitted by the Board of Health, the period varying in different communities, but being in all cases dependent upon cultures from the throat of patient and nurse showing no diphtheria bacilli. B. General management. Bed is to be insisted upon in all cases, and rest in the recumbent position is very important, owing to the toxic action of the diphtheritic poison on the heart. The nurse must be careful not to let the patient sit up suddenly, as children are apt to do, as cases are on record where such exertion has caused sudden giving out of the heart with immediate death. The bowels are to be kept open and the mouth clean with some mild antiseptic wash. Gargling is not advisable, as it practically always necessitates sitting up. Food should be liquid and semi-solid, bland, easily digestible, and given frequently in small amounts. Swallowing is at first usually very painful, and it may be very difficult to get patients, especially children, to eat a sufficient amount. In toxic cases, stimulation is to be resorted to, differing in no wise from that given in any disease complicated by heart weakness. For the paralysis following diphtheria, strychnia seems to exert a more beneficial effect than any other drug. The patient should be kept in bed until convalescence is fully established, because of the danger of sudden heart failure, even after all signs of active diphtheritic disease have disappeared. Cold to the throat in the form of cold cloths is often beneficial. The ice bag is often very efficient in relieving pain. Opiates may have to be given. 2. Specific treatment. There is probably no more brilliant achievement in internal medicine than the triumph gained over diphtheria by the discovery of Diphtheria antitoxin by von Behring in 1890. Antitoxin. Antitoxin is obtained by injecting horses with gradually increasing doses of diphtheria toxin, until an immunity has been established, so that the animal can withstand, with no harmful effects whatsoever, doses that would have proved immediately fatal if given at first. When the horse is sufficiently immunized, he is bled, and in the blood serum is found the diphtheria antitoxin, i.e., a substance which is capable of neutralizing and rendering harmless the diphtheritic poison circulating in the patient's blood. The measure adopted for estimating the amount of antitoxin is the unit. The serum of the horse is standardized and put up in syringes ready for use, each holding a certain number of units of antitoxin: 500, 1000, 2000, 5000, 10,000, as the case may be. Diphtheria being strictly a toxic disease, i.e., the poison manufactured by the diphtheria bacilli being the one harmful factor. If enough antitoxin is injected to neutralize all the toxin circulating in the blood, the patient has an excellent chance for recovery. A. Prophylactic treatment with antitoxin. It is customary to give the nurse and all members of the family a preventive injection of antitoxin, from 500 to 1000 units, according to the age of the individual to whom it is given. This prophylactic injection establishes an immunity to diphtheria which lasts about 3 weeks. B. Active treatment with antitoxin. Antitoxin should be administered as soon as the diagnosis is made, and in doubtful cases in the absence of a positive diagnosis, because if the case is one of diphtheria, it will do good, while if the case is one of follicular tonsillitis, no harm will result, and because mortality from diphtheria increases in direct proportion to delay in the administration of antitoxin. Antitoxin is administered hypodermically, the loose tissue of the back below the angle of the scapula being the favorite site of injection. The dose depends upon the judgment of the physician. Some believe in relatively small doses, 2,000 to 5,000 units, others in moderately large doses, 10,000 to 30,000 units, and still others in enormous doses, 50,000 to 100,000 units. From this it will be apparent that, practically speaking, there is no such thing as an overdose of antitoxin. If the symptoms do not improve after the first injection, another is given from 8 to 12 hours later, and subsequent doses are given as indicated. Where antitoxin has a beneficial effect, in from 6 to 18 hours the membrane is seen to grow less and finally to disappear. The temperature drops and all signs of toxemia are reduced in intensity, the throat being often almost normal within 3 or 4 days. In more severe cases, a longer time is necessary for recovery, and in the fulminant cases, or in those in which antitoxin administration has been delayed, until the entire body is flooded with poison, death ensues. In cases of laryngeal diphtheria, in addition to antitoxin administration, always in larger dosage than in pharyngeal cases, mechanical means may be necessary to relieve the blocking up of the larynx and consequent death of the patient from suffocation. These are two in number. 1. Intubation, by means of a special instrument for its insertion, devised by the late Dr. Joseph O'Dwyer of New York. A hollow tube is passed into the larynx until it is between the vocal cords, where it lodges and is held in place by means of a groove at its upper end. The patient is able to breathe through the tube until the membrane lessens in amount and the larynx is again clear, when the tube is extracted if the patient fails to cough it out. 2. Tracheotomy. If intubation is impracticable, an opening is made in the trachea and a tracheotomy tube inserted through which the patient can get air. End of chapter 25. Chapter 26 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 26. Anterior Poliomyelitis, Infantile Paralysis. Definition: an acute infectious disease occurring both in epidemics and sporadically due to a filtrable and cultivable virus, involving different parts of the nervous system, often localizing especially in the anterior horns of the gray matter of the spinal cord (poliomyelitis anterior), but also localizing in the cerebrum, in the medulla oblongata, in the cerebellum, and in the meninges to a variable extent in different cases. Since the epidemic of poliomyelitis in New York in 1916, the medical thought of the country has been markedly concentrated upon this disease. Etiology. After many experiments, it has been established that the juices of the nervous system of an infected animal, when filtered through porcelain or some other filter, are still able to infect monkeys. Hence, the disease is due to a filtrable virus. This virus is most concentrated in the nervous system of the patient, but is also to be found in the mesenteric glands and in the tonsils and throat. The virus stands cold well, retaining its virulence when kept frozen for at least 11 days. It is enfeebled by a temperature of 45°C and is killed after heating for half an hour at 55°C. It is not killed by drying. It can live for some time in sterile water or sterile milk, apparently without multiplication." Unquote. Barker. The transmission of the infection by the stable fly, insects, fomites, etc., is still a debatable point. The disease is present chiefly in midsummer and in the fall, though cases occur at all seasons of the year. The vast majority of those attacked are children from 1 to 4 years of age. Pathology. Formerly, it was believed that destruction of the anterior horn cells of the spinal cord was the sole characteristic lesion of poliomyelitis. Latterly, it has been found, however, that the lesions of a localized or generalized meningitis may be present, the process being situated in the cerebrum, cerebellum, or medulla oblongata, as the case may be. In many cases, the majority of those positively recognized, the anterior horn cells are the structures most damaged. They show signs of degeneration, and as a result, the motor nerve fibers arising from these cells degenerate, with resultant paralysis of the muscles supplied. Some of the motor cells in the anterior horns of the cord are wholly destroyed. Others recover partially. Still others recover completely. This accounts for the gradual recovery from the paralysis, for as function is regained on the part of the motor cells, regeneration of the nerve fibers takes place and impulses that cause the muscle to contract are again transmitted. Symptoms. The incubation period is usually about a week. In the typical case, the child is taken suddenly ill with symptoms in no wise characteristic. They are often thought to be due to tonsillitis or influenza. There is usually vomiting, sometimes diarrhea, moderate fever ranging from 101 to 103 degrees, with the usual symptoms that accompany a febrile disturbance. There may be pain in the limbs, rigidity of the neck, and symptoms suggestive of meningitis (QV). The characteristic feature of the typical case is paralysis, which appears within a week of the onset. In infants and very young children, this paralysis may not be noticed for several days, though obviously present when sought. In older children, paralysis is, of course, noticed as soon as it appears. At first the paralysis may seem to affect one or more limbs in their entirety, but it soon manifests its rather characteristic distribution. The muscles are usually affected in groups, corresponding to the particular segment of the spinal cord in which the anterior horn cells have been most damaged, and are rarely affected singly. Thus, the peroneal muscles on the outer side of the leg may be involved, the extensor muscles of the front of the thigh, the deltoid group covering the shoulder, some of the muscles of the forearm, etc. Usually more than one group is involved at first. The paralysis is what is termed flaccid, i.e., the paralyzed limb lying quite loosely. There is no disturbance of sensation, though at times the limb may be cool to the touch and slightly edematous. The actual febrile period lasts usually from a few days to 2 weeks. In bad cases, the patient may be overwhelmed with toxemia and die in a few days, or else death may ensue as a result of paralysis of the muscles of respiration. After the acute febrile period has passed, the stage of repair begins, which may last as long as 2 years. It is important to remember that paralysis is always most extensive at first, that practically every case shows marked improvement over the condition as it existed at first, and that complete recovery occurs in about 20% of the cases. In the course of epidemics, many atypical cases are seen, some showing damage to the various cranial nerves as shown by facial and ocular paralyses of varying degrees of severity, others giving symptoms of a multiple neuritis, pain along the course of certain nerves, sensitiveness to touch, and paralysis. Still others showing symptoms almost characteristic of meningitis (QV). In the course of epidemics, stress must be laid upon the abortive forms of poliomyelitis, where no paralysis occurs, although the general symptoms of illness may be present, i.e., fever, together with symptoms suggesting a respiratory, meningeal, or general influenzal infection. Every transition stage is noticed between these non-paralytic forms and those showing most extensive loss of function. It is now believed that in large epidemics of poliomyelitis, from 1/3 to 1/2 of all the infections are abortive forms. Prognosis. The death rate varies between 10 and 40%, according to statistics of various epidemics. Death usually occurs on the 4th or 5th day, and the mortality is greater in adults than in children. Prophylaxis. At present, prophylaxis does not seem to be of much service. The modes of transmission of the virus of the disease are insufficiently known, and in epidemics the great number of undiagnosed and abortive cases, as well as the numbers of healthy adults acting as carriers, make any attempt at satisfactory isolation and quarantine practically impossible. The patient should, of course, be isolated, and other children in the family kept away from school for at least 8 weeks. All discharges from the nose, throat, bladder, and rectum should, when possible, be destroyed by burning. Those individuals not affected should have the nose and mouth sprayed with some mildly antiseptic solution. In times of epidemics, schools should be closed, children's parties not held, and all children should be watched carefully to see that they never use any article belonging to any other child. Disinfection of the sick room is imperative, and, if possible, fumigation of the entire premises after a case of poliomyelitis is desirable. Treatment. During the acute stage of the disease, the management is that of any febrile affection. Bed, liquid diet, attention to the bowels and kidneys, cold or heat applied to painful areas, and sedatives when indicated. The management of the stage of repair in poliomyelitis is a very complicated matter, and cannot be taken up in detail. Much depends upon the competence of the nurse, and upon the zeal with which she executes the physician's orders as to the different measures to be carried out. These orders should be given in great detail, preferably in writing, as should they be misunderstood and wrongly carried out, irremediable harm may result. The general management of the stage of repair in poliomyelitis consists in the prolonged and judicious application of the following therapeutic agencies: 1. Electricity. 2. Massage. 3. Local heat. 4. Exercise. 5. Orthopedic apparatus, braces. 6. Surgical operations planned to help the damaged muscles in the resumption of their proper function. End of chapter 26. Chapter 27 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 27. Epidemic, Cerebrospinal Meningitis. This disease occurs both in epidemics and in single scattered cases. It is most prevalent in the winter and spring months, occurs most frequently in crowded quarters where there is faulty hygiene, and may be communicated by the secretions of the nose, mouth, and conjunctiva. Whether it can be communicated by insects has as yet not been determined. Etiology. The disease is caused by a specific germ, the Diplococcus intracellularis meningitis of Weichselbaum. This organism is always present in the bodies of the leukocytes in the spinal fluid in epidemic meningitis, and has also been found in the secretions of the nose, mouth, and eye. Pathology. The characteristic changes found are limited to the meninges of the brain and spinal cord. 1. Brain. The meninges, membranes, are congested and inflamed. There is an exudate of serum and pus at the edges of the brain, and extending over the upper and outer surface, the convexity of the brain. The brain tissue itself is the seat of congestion, hemorrhages, thrombi, and small abscesses. 2. Cord. The meninges and body of the cord are affected in a manner similar to those of the brain. The central canal of the cord and the ventricles of the brain are dilated, the amount of spinal fluid is increased, the fluid itself is turbid and is under much greater pressure than normal. Symptoms. These vary greatly in various epidemics. In a typical attack, the onset is sudden, with severe headache, vomiting, and temperature from 102 to 104 degrees. The headache increases in intensity and becomes agonizing. There is sensitiveness to light and sometimes to sound. The neck becomes stiff and the head is retracted. Any attempt to bend the head forward causes excruciating pain. The reflexes, knee jerk, wrist jerk, etc., are markedly increased. Koenig's sign is present, inability to extend the leg fully when the thigh is placed at right angles to the trunk. The pupils are at first contracted and usually equal. There may be an eruption of herpes on the lips, or else herpes zoster, shingles, may appear on the body. All the signs hitherto enumerated are those of cerebral irritation. With the further progress of the disease, the signs of cerebral depression set in. In a fully developed case, the patient is in a semi-conscious, delirious, stuporous, or comatose condition, usually lying on the side in a crouching position, the head retracted, the legs drawn up, the arms bent at the elbows, i.e., nature seeking the position of greatest relaxation. The high fever may fall to subnormal. The patient may be quiet, or else toss restlessly about. When aroused, he may show signs of irritability and excessive sensitiveness. There is usually an increase in the leukocytes. The course of the disease is very varied. Excessively severe cases may result in death within a few hours. Other cases may last many weeks, the fever running an irregular course. Usually the disease is at its height for 5 or 6 days, after which the symptoms gradually abate. The complications of cerebrospinal meningitis are not numerous, but are very serious. 1. Otitis, common and often resulting in deafness, which is absolute and incurable. If the patient is very young, deaf mutism is the result. 2. Pneumonia, frequent and very fatal. 3. Hydrocephalus, not so frequent but very fatal. Prognosis: the outlook is always very grave. Previous to the discovery of anti-meningitis serum, the mortality was excessively high, 80% or more. Since the serum has been used, mortality has been greatly reduced, but still remains about 25%. Lumbar puncture, Lumbar puncture is used as a method of diagnosis and as a method of treatment. It is a procedure that the nurse will never be called upon to carry out, but it is one that she will witness and in the performance of which she will lend assistance. Therefore, she should understand what is being attempted and what information is being sought from the procedure. By lumbar puncture is meant the insertion of a hollow needle into the spinal canal and the withdrawal through the needle of the spinal fluid for the purposes of 1. Examination; 2. Lessening intracranial pressure; 3. Both of the preceding; 4. As a preliminary measure to the injection of certain drugs or sera. For the performance of lumbar puncture, the nurse in attendance should have the following articles in readiness: 1. Needles, sterilized; 2. Iodine; 3. Gauze and sponges; 4. Gloves for the physician; 5. Sterile cotton; 6. Sterile test tubes, 2. To receive fluid; 7. Collodion. The patient is turned on the side with his back toward the operator and drawn as near as possible to the edge of the bed. The thighs are flexed on the trunk and the legs on the thighs and the back is bowed forward as much as possible, so as to increase the space between the vertebrae. The nurse usually holds the patient in this position while lumbar puncture is being performed. Usually no anesthetic is necessary and the procedure is, as a rule, simple and rapid for one accustomed to it. The site chosen for lumbar puncture is between the second and third or third and fourth lumbar vertebrae. Normal spinal fluid is absolutely clear and escapes from the needle at the rate of about 8 drops to the minute. If the fluid is under pressure, it may run in a steady stream or spurt several feet. The following statements are true in a general way. If fluid is clear and under no excessive pressure, normal. If fluid is clear and under excessive pressure, tuberculous meningitis. If fluid is turbid and under excessive pressure, probably epidemic cerebrospinal meningitis or some septic meningitis. If fluid is blood-stained, no immediate inference can be drawn. Treatment. Prophylaxis should be the same as for typhoid fever, QV. Thanks chiefly to the work of Dr. Simon Flexner of the Rockefeller Institute in New York, a serum has been manufactured that greatly detracts from the terrors of epidemic cerebrospinal meningitis. This is anti-meningitis serum. Anti-meningitis serum is obtained, as is diphtheria antitoxin, from horses which have gradually been immunized to large doses of the poison of the germ causing cerebrospinal meningitis. The serum is of value in this disease alone, and it is of no use in any other form of meningitis. A lumbar puncture is done, and if the diplococci of cerebrospinal meningitis are found in the spinal fluid, injections are given daily for 4 days, and the signal for cessation of treatment is failure to find any more diplococci in the cells of the spinal fluid. The remainder of the treatment of this disease is purely symptomatic and consists in giving the patient as much nutritious food as possible, in keeping the bowels well open, in giving sedatives for pain, and in giving stimulants when needed. End of chapter 27. Chapter 28 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 28. Syphillis. Syphilis is a specific infectious disease caused by the presence in the tissues of the infected individual of the Spirocheta pallida. A nurse is practically never called upon to care for a case of syphilis as such, for those cases do not require nursing. She will, however, be called upon to nurse many individuals who have or have had syphilis, and she should realize and appreciate the enormously important role played by this disease in predisposing to, or actually bringing about, other pathological conditions. A very brief review of syphilis itself will be given, and then a few words will be said concerning its causal relationship to other diseases. It has been determined beyond a doubt that syphilis was first brought to Europe from Hispaniola or Haiti in 1493 by the sailors with Columbus on his first voyage of discovery. The disease began to be noticed during the invasion of Italy by Charles VIII of France in 1494 in order to conquer Naples, with an army of mercenaries from all parts of Western Europe. With the defeat of Charles' army, the disease was traced by the scattering of his troops, and appeared in France, Germany, and Switzerland in 1495, in Holland and Greece in 1496, in England and Scotland in 1497, and in Hungary and Russia in 1499. As is usual with the initial appearance of a disease among a people unused to its presence, during the first decades of its prevalence, syphilis raged with extraordinary severity. But at the end of 50 years Europeans had developed a certain amount of immunity to it, and the cases becoming milder and more chronic, assumed the type seen today. Syphilis is usually acquired during sexual intercourse, and the first sign of it, the initial lesion or canker, is therefore most frequently to be found on the genitals. Infection cannot take place unless the mucous membrane is broken, but the abrasion may be of microscopic size. Individuals in the so-called secondary stage of the disease, with mucous patches in their mouths, can infect others by kissing, the initial lesion then showing itself on the lips or in the mouth. Schamberg reports a case where a young man with a chancre of the lip infected 7 young girls at a party where kissing games were played. The course of syphilis falls naturally into several stages. A brief summary of these stages may serve to give a clear picture of the disease. 1. Incubation period. From the time of infection to the appearance of the initial lesion, approximately 4 weeks. 2. Primary stage, lasting about 6 weeks. During this period the canker, which is a small ulcer with a hard base and covered by a small amount of clear secretion, develops and disappears. The infection gradually invades the entire body, and the period is abruptly brought to an end by the appearance of the eruption or rash. 3. Secondary stage. Begins with the appearance of the rash, and ends only with the disappearance of evidences of an active systemic infection. It may last for a few weeks, several months, or more than a year, and may be accompanied by slight fever, some loss of weight, and a mild degree of general malaise. The rash may assume one of many forms. 4. Tertiary stage. Characterized by the presence of lesions due to isolated local syphilitic processes, situated anywhere in the body, and affecting most frequently the blood vessels, liver, brain, central nervous system, and bones. Syphilis thus presents resemblances to 3 types of disease. First, a local infection characterized by a local lesion, the canker. Second, it resembles the acute specific infections, especially the eruptive fevers. Third, by the formation of localized foci of inflammation, it resembles tuberculosis. The secondary manifestations of syphilis are those of an acute systemic disease. The tertiary manifestations are those of a chronic disease sharply localized in its activity. Syphilis rarely directly kills the patient. Its most dreaded effects are remote and are exerted upon various organs and tissues of the body. A few historical facts of very recent date may be of interest as showing the epoch-making contributions of the 20th century to the knowledge of this important disease. In 1903, Metchnikoff and Roux demonstrated that apes could be inoculated with syphilis. In 1905, Schoeden and Hoffmann discovered the Spirocheta pallida, which is the sole cause of syphilis. In 1906–7, Wassermann, Neisser and Bruck developed the Wassermann reaction as a test for the presence and diagnosis of syphilis, which has enabled many thousands of cases to be recognized and treated that could not have been diagnosed by any of the previous methods at the physician's command. In 1909–10, Ehrlich discovered and gave to the profession 606, or salvarsan, a preparation of arsenic for the treatment of syphilis. Hereditary syphilis. Syphilis can be, and often is, directly transmitted from the mother to the child she is bearing. If the child is born actively syphilitic, it usually dies in a few weeks at most, and during its life it is acutely ill. The skin and mucous membranes are markedly affected by the syphilitic eruption. There is severe running at the nose and laryngitis. The nasal discharge is purulent, and the child snuffles and breathes with difficulty. Because of the laryngitis, it frequently has a characteristic high-pitched, harsh cry. It is emaciated, and the liver and spleen are usually enlarged. If the child is born infected, but with no active symptoms, these begin in from 2 to 6 weeks. Snuffles is usually the first symptom, to be followed by those described in the preceding paragraph. If treated, many of these cases recover. For a woman to bear a syphilitic child, she must be herself actively syphilitic. If the disease is inactive, a syphilitic mother will bear healthy children, while later, if the disease reawakens, she will bear syphilitic children. Prophylaxis of syphilis. This cannot be dealt with here. The question is a vast one indeed, and is as much sociological as medical. Syphilis and its spread are so intimately connected with the questions of prostitution, loose morals, the relations of the sexes, that to touch the question at all would be to plunge into very deep water. Treatment of syphilis. For several centuries, mercury has been known as a specific remedy for the syphilitic poison. It has been administered by inunction, by mouth, and hypodermically. It is still one of the mainstays of treatment. Salvarsan is the newest substance for combating syphilis. Ehrlich hoped that by the administration of salvarsan intravenously he could definitely cure syphilis. This hope has not been fully realized. Valuable as salvarsan is, it has been found that the best results are obtained when it is combined with vigorous treatment with mercury. Syphilis in its relationship to other diseases. This aspect of syphilis is one of the most important to be considered. Diseases directly or remotely due to the syphilitic poison may appear many years after all symptoms and signs of syphilis have disappeared, and up to the present time, no method of treatment has been devised that will prevent the later effects of this disease. By the action of the syphilitic poison on the blood vessels, arteriosclerosis is frequent, and there are authorities who assert that every case of aneurysm not due to injury has, as at least one of its causative factors, syphilis. As a result of arterial sclerosis, the kidneys are damaged and the heart overtaxed, giving rise to the condition described as cardiovascular renal disease. It has been shown beyond a doubt that locomotor ataxia and paresis, softening of the brain, are always late results of syphilis. These two diseases, both very serious and incapable of cure, arrest being the best result attainable by any form of treatment, form one of the saddest chapters occurring in middle life as a remote effect of a syphilitic infection, received perhaps a quarter of a century before. By its action in lowering bodily resistance, syphilis plays a part in the causation of almost every disease known to man. Sir William Osler has said that, "The man that knows syphilis in all its manifestations knows most of medicine," and it is important for the nurse to appreciate the rôle played in the human body by this disease. One of the reasons that syphilis has so many remote effects is that the disease in its active form is singularly yielding to treatment. Symptoms disappear rapidly and apparent health returns. The patient realizes with difficulty that from 1 to 3 years of treatment are necessary to thoroughly eradicate the Spirocheta pallida. With a return of physical well-being, treatment is maintained half-heartedly, if indeed it is not wholly abandoned, and many of the Spirochetas, unharmed, bury themselves deep in the tissues, where they hibernate in safety, to make their activities felt in after years in the form of a variety of pathological conditions. End of chapter 28. Chapter 29 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 29. Locomotor Ataxia, Teres dorsalis. Locomotor ataxia is a disease of the sensory portion of the central nervous system and is characterized anatomically by a sclerosis or fibrous tissue formation in the posterior columns of the spinal cord, known as the columns of Gall and Burdock. It has been established that this disease is always a late result of syphilis and may occur in an individual that has to all appearances been cured of that infection and in whom no symptoms whatsoever have been present for as much as 25 years. Symptoms. 1. Incipient stage. 1. Pain, sharp, stabbing, called lightning pains, most common in the legs. 2. Ocular symptoms. Paralysis of external muscles of the eye, ptosis, drooping of upper lid, and Argyll-Robertson pupil, in which the pupil loses its sensitiveness to light, but continues to react to accommodation. 3. Difficulty in voiding urine. 4. Loss of patellar reflex, knee jerk. Any or all of these symptoms may exist for several years, the patient remaining in a stationary condition. 2. Ataxic stage. This develops gradually. One of the first indications to the patient is inability to get about readily in the dark, or to maintain his equilibrium when washing his face with the eyes shut. When the patient stands with the feet together and the eyes closed, he sways and has difficulty in maintaining his position, and he may be quite unable to stand on one leg. He does not start off promptly at the word of command. On turning quickly, he is apt to fall. He descends stairs with more difficulty than he ascends them. Gradually, the characteristic ataxic gait develops. The patient, as a rule, walks with a stick. The eyes are directed to the ground. The body is thrown forward and the legs are wide apart. In walking, the leg is thrown out violently, the foot is raised too high, and is brought down in a stamping manner with the heel first, or the whole sole comes in contact with the ground. Ultimately, the patient may be unable to walk without the assistance of two canes. This gait is very characteristic and unlike that seen in any other disease. The incoordination is not only in walking, but in the performance of other movements. It may early be noticed by a difficulty which the patient experiences when buttoning his collar, or when performing one of the ordinary routine acts of dressing. One of the most striking features of the disease is that with marked incoordination there is no loss of muscular power." Osler. Shifting pains persist and render many patients miserable. Attacks of severe pain referable to various organs of the body may occur. The so-called gastric crises are the most important. Attacks of pain in the stomach accompanied by nausea and vomiting. 3. Paralytic stage. After the ataxia stage has persisted for an indefinite time, the patient gradually loses the power of walking and becomes bedridden or paralyzed. In this stage, the condition known as surgical kidney, or ascending infection of the urinary tract, is apt to occur, or the patient may succumb to some infection such as pneumonia or tuberculosis. Prognosis. Recovery is impossible, for certain fibers in the spinal cord are permanently destroyed. Arrest at any stage is often possible. Treatment. Antisyphilitic treatment energetically instituted is indicated in practically every case. Salvarsan combined with mercury gives the best results. Large doses of potassium iodide, formerly extensively used, are no longer considered advisable. The patient must be placed under the best possible hygienic surroundings, well fed, the avenues of elimination kept open, and particular attention paid to the skin, the nutrition of which is often interfered with. If bed sores develop in these patients, they are apt to run a rapid and virulent course, and may prove fatal. Frankel has devised some special exercises for the reeducation of coordination, which are of value. The general treatment of locomotor ataxia, apart from the antisyphilitic medication and Frankel's exercises, is largely symptomatic, and in a disease characterized by so many symptoms and extending over such a lengthy period of time, a recital of all methods employed would be too voluminous. End of chapter 29. Chapter 30 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 30. Diabetes Mellitus. Diabetes is a disease of nutrition, in which sugar, glucose, cannot be utilized in the usual way. Hence it appears in the blood and is excreted in the urine, glycosuria, the amount of which is greatly increased. Etiology. Heredity seems to play an important part. The disease is most frequent after 40 years of age, and generally speaking, the earlier in life an individual is affected, the more severe is the type of the disease, and vice versa. Diabetes often develops after an infection or an injury. The pathology is cloaked in such complexity and obscurity that no mention will be made of it. Symptoms. The disease is gradual and insidious in its onset. Often the first symptom is sugar in the urine, which is accidentally discovered in the course of a routine examination, as, for instance, for life insurance. Other symptoms which are rather characteristic are: 1. Excessive hunger; 2. Excessive thirst; 3. The passing of an exceedingly large amount of pale, straw colored urine, from 3 to 10 quarts in 24 hours; 4. Emaciation and increasing weakness; 5. Crops of boils or carbuncles; 6. Intense itching, often about the genitals; 7. The characteristic urinary findings: A. Large amount of urine voided; B. High specific gravity, 1.030 to 1.045; C. The presence of sugar. In untreated cases, the disease progresses steadily and a condition known as acidosis appears, i.e., the overloading of the body with acids. Substances known as beta oxybutyric acid and acetone appear in the urine. The appearance of these chemical compounds paved the way for the last act in the evolution of the disease. 8. Diabetic coma. This may come on with weakness, a sweetish odor to the breath due to acetone, somnolence and gradually developing unconsciousness, the patient dying in a few hours. Diabetic coma may begin with nausea, vomiting, headache, delirium, great distress and dyspnea. Finally, there are cases in which, without any previous warning, the patient is seized with headache, a sense of intoxication, and rapidly passes into a deep coma which ends in death. Complications. The manifestations in the skin have been mentioned. It is a fact that diabetics show very little resistance to infection, and that in them trivial wounds and scratches become the starting point for a spreading cellulitis, ending often in gangrene. Pulmonary tuberculosis is not infrequent, and is very fatal. Albuminuria is also of fairly common occurrence. Prognosis. In untreated cases of diabetes, the outlook is absolutely bad. Under careful management, much can be done for the patient, though it is not possible to speak of cure in connection with this disease. However, in the mild and moderately severe types, judicious treatment will prolong life for years under very comfortable conditions, but vigilance must never be relaxed, for the roots of sin are there, and if the patient insists on exceeding his dietetic limitations, he soon pays for his indiscretion by a return of the old train of symptoms. In the severest types of the disease, but little can be done. Treatment. The treatment of diabetes is receiving a great deal of attention at present, and it is a transition stage, for many ideas that had taken root firmly are threatened in their security by the work of Dr. Frederick M. Allen and his so-called starvation treatment. The problem of the management of the diabetic is becoming better understood, and the outlook for the patient is becoming proportionately more hopeful. The first thing to be done with a diabetic is, of course, to determine his carbohydrate intolerance. In other words, to discover how much carbohydrate food he can care for without sugar appearing in the urine. In order to determine this factor, the urine must be first rendered sugar-free. This is done by one of two methods. 1. Gradual withdrawal of carbohydrate foods. 2. Sudden and complete withdrawal of all foods. Allen's starvation method. 1. Gradual withdrawal of carbohydrate foods. The patient is placed on an ordinary diet for a couple of days, and the amount of sugar in the 24-hour urine is determined. He is then placed on a strict or carbohydrate-free diet. See accompanying list compiled by Dr. E. P. Joslin of Boston. Plus 100 grams white bread, 60 grams carbohydrate, for 3 days. Each day the amount of sugar in the 24-hour urine is determined. In very mild cases, the urine may become sugar free in 3 days or less. In moderately severe cases, the sugar output may fall to between 20 grams and 10 grams. In severe cases, the amount of sugar may equal the 60 grams of carbohydrate taken in or even exceed that amount. In mild cases and in those of medium severity, after the urine has been rendered sugar free, 20 grams of white bread may be added to the diet every other day until sugar reappears in the urine, and when this occurs, the total amount of white bread tolerated is easily known. This amount must never be exceeded, though substitutions can be made as shown by the accompanying convenient table. While testing carbohydrate tolerance, sodium bicarbonate should be given when the carbohydrate intake falls below 60 grams. 2. Sudden and complete withdrawal of all foods. This method of managing diabetes has been in use but since 1914. The results are as yet inconclusive. It holds forth such promise, however, and is so extensively in use among those best qualified to judge, that the nurse should be familiar with the general principles involved. Under this method of treatment, the patient is compelled to fast until the urine is sugar free, and for 24 or 48 hours longer. In severe cases, alcohol, being a food that does not cause glycosuria, is given. Sodium bicarbonate is also administered for the first few days, but is then discontinued. After the urine has been sugar free for from 24 to 48 hours, feeding is undertaken very slowly and cautiously, but not according to any fixed program, since it is desirable to individualize the diet to suit the special need of the particular patient. The only requirement is that the urine shall remain sugar free. The appearance of even a trace of sugar is the signal for a fast day. The original fast may last from 2 to 10 days. Subsequent fasts, according to Allen, need never exceed 1 day. To obtain carbohydrate tolerance, 200 grams of vegetables of 5% class, see Joslin's table, are added, increasing until sugar appears in the urine. A fast day is at once instituted, and, the carbohydrate tolerance being known, the limit is not exceeded. Protein tolerance is also estimated by adding gradually to the dietary eggs and meat, until sugar appears in the urine, or a quantity of protein sufficient for the needs of the body is being consumed. In some cases, fat tolerance must be determined as well. During the fast, patients lose considerable weight. This Allen considers beneficial. Later, the patient is permitted to gain weight as long as he can do so without the reappearance of glycosuria. The accompanying schema and tables of Dr. Joslin, pages 248 through 9, give in concrete form a working basis for the management of cases of diabetes by the Allen method. These will not be read. Drugs play a very small part in the management of cases of diabetes. At one time, opium in large doses, usually in the form of codeine, was widely used. Arsenic has many adherents. Many other drugs have been recommended, but have failed to be of lasting benefit. Diabetic coma. As coma is one of the manifestations of acidosis, the patient should be saturated with alkalis. Sodium bicarbonate is usually used, by mouth, by rectum, or intravenously. Free catharsis, obtained usually by use of salines, is indicated. Oxygen, by inhalation, may lessen the air hunger and dyspnea. Recovery from coma is rare but not impossible. Itching. This is often almost intolerable. Prolonged warm soda baths are of aid, and mild solutions of ammonia water and phenol help. Vaginal douches are of aid and scrupulous cleanliness of the parts is important. In diabetes, as in almost no other disease, the nurse can be of inestimable aid to the physician and to the patient. With a knowledge of the principles of treatment, with reference to tables giving food values and with ability to make the very simple test for the presence of sugar, not the quantity present, she can take a case along from day to day very satisfactorily, and can make the small individual changes and variations in the patient's dietary, thus relieving the doctor from details. End of chapter 30. Chapter 31 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 31. The Blood. The blood is the nutritive medium of the body, distributes food and oxygen to all the tissues, and takes from them waste products to be delivered to the organs of elimination. It comprises about 1/13 of the body weight. The blood is composed of a liquid portion, blood plasma, in which are floating the cellular elements or corpuscles of the blood. 1. Red blood cells, erythrocytes. 2. White blood cells, leukocytes. 3. Blood platelets. Plasma. Normally, when free from corpuscles, plasma in thin layers is clear and colorless. When seen in thicker layers, it has a faint yellow tinge. Blood, upon escaping from the blood vessels, usually clots. The clot, in its formation, shrinks and squeezes out a fluid having a slightly yellow tinge. This is known as blood serum. It may be said that plasma is the liquid part of blood before clotting, and serum the liquid part of the blood after clotting. In the blood serum are contained many of the substances that figure so largely in the different phases of immunity. These will be touched on in the chapter on immunity. Clotting. One of the most remarkable properties of blood is its power to coagulate or clot immediately or very shortly after escaping from the vessel. This power of clotting saves the life of each one of us countless times. For were it not for the blood clot, we would all die of hemorrhage from the most trivial injury. There are indeed individuals known as hemophiliacs, or bleeders, whose blood clots very slowly, if at all, and who frequently bleed to death from some very trifling cut or operation. Quote, the essential part of the blood clot is the fibrin. Fibrin is an insoluble proteid which is absent from normal blood. In blood that has been shed, and, under certain conditions, in blood while still in the blood vessels, this fibrin is precipitated, if the word may be used, in the form of an exceedingly fine network of delicate threads, which permeates the whole mass of blood, and gives the clot its jelly-like character. The shrinking of the threads causes the subsequent contraction of the clot. If the blood has not been shaken in the act of clotting, almost all the red corpuscles are caught in the fine fibrin meshwork, and as the clot shrinks, these corpuscles are held more firmly, only the clear liquid of the blood being squeezed out, so that it is possible to get specimens of serum containing few or no red corpuscles. The leukocytes, on the contrary, although they are also caught at first in the forming meshwork of fibrin, may readily pass out into the serum in the later stages of clotting, on account of their power of amoeboid movement. See chapter on immunity. If the blood has been agitated during the process of clotting, the delicate network will be broken in places, and the serum will be more or less bloody. That is, it will contain numerous red corpuscles. If During the time of clotting, the blood is vigorously whipped with a bundle of fine rods. All the fibrin will be deposited as a stringy mass upon the whip, and the remaining liquid part will consist of serum plus the blood corpuscles. Blood which has been whipped in this way is known as defibrinated blood. It resembles normal blood in appearance, but is different in its composition. It cannot clot again." Unquote. An American Textbook of Physiology. The cellular elements of the blood. 1. Red cells, or erythrocytes. These are small biconcave discs, practically round when normal, and having in the fresh state a yellowish color when looked at under the microscope. They are very numerous, there being in men about 5,000,000 to the cubic millimeter, and in women about 4,500,000. A normal red cell is never nucleated. In anemia from any cause, the red cells are reduced in number and changed in character. To what extent depends upon the severity of the anemia. The lowest red blood count on record is 143,000 per cubic millimeter. The following changes may take place in red cells as a result of severe anemia. A. Great pallor, due to deficient amount of hemoglobin. B. Poikilocytosis, or irregularity in outline. Nucleation, normoblasts, due to the throwing into the circulation by the bone marrow of young immature forms, in order to supply the crying need for blood cells. D. Appearance of large nucleated red cells, megaloblasts, representing still more immature forms thrown out when the body's need for new cells is most urgent. E. Stippling of red cells, a form of degeneration. 2. White cells or leukocytes. These cells are far less numerous than the red cells, a normal leukocyte count showing from 4,000 to 7,000 per cubic millimeter. There are several varieties of leukocytes. The following table gives the main varieties and the approximate percentage in normal blood. Polymorphonuclear neutrophil, 65%. Small lymphocyte, 20%. Large lymphocyte, 10%. Eosinophil, 3%. Basophil, mast cell, 2%. Total 100. The leukocytes, as mentioned above, are capable of motion by means of their power of amoeboid movement, and are very active as scavengers of the body, and as taking a prominent part in the fight against infection. This function is referred to in the chapter on immunity. Leukocytosis. By leukocytosis is meant an increase in the number of leukocytes in the blood. Practically all leukocytosis is pathological, i.e., is called forth by the presence of an enemy in the form of some infection. The exception to this rule lies in those blood diseases known as the leukemias, where, owing to an abnormality of the blood-forming organs, especially the spleen, a vast number of immature leukocytes are flung into the circulation. Leukocytosis occurs in all infections and infectious diseases except 1. Typhoid fever. 2. Uncomplicated tuberculosis. 3. Malaria. 4. Influenza. 5. Measles. 6. Mumps. 7. Leprosy. The usual count when a moderate leukocytosis exists is from 15,000 to 30,000. Occasionally the count will be as high as 50,000 or 75,000. In the leukemias, the white cells may number 500,000 to the cubic millimeter, and even more. The presence or absence of a leukocytosis is often of great value in diagnosis, and the nurse should appreciate its importance and learn to understand its significance in conditions where the count is frequently made. The following rules may prove of aid. 1. If the infection is severe and the patient's resistance good, leukocytosis is early, marked, and persistent. 2. If infection and resistance are both less marked, but fairly well proportioned, one to the other, leukocytosis still occurs, but comes later, is less in degree, and ceases more quickly. 3. If the infection is one of unusual virulence, as in the so-called fulminating cases of sepsis, diphtheria, or pneumonia, no leukocytosis occurs. 4. Occasionally, when the infection is unusually mild and the resistance unusually good, there may be little or no leukocytosis. Hemoglobin. The hemoglobin is the coloring matter of the red cells and is the substance to which the blood owes its red color. A chemical change in the hemoglobin, in combination with each red cell, is responsible for the fact that arterial blood is bright red and venous blood a deep crimson. See chapter on the circulation. Hemoglobin estimations are very frequently made, the test being the most simple of any applied to the blood. Normal hemoglobin content ranges from 90% to 110% on the scale with which the blood under examination is compared, and in all probability treatment would rarely be instituted with a normal red cell count and hemoglobin 80% or over. Hemoglobin varies pathologically in three ways. 1. Proportionately to the loss in red cells, i.e., with a red cell count of 3,750,000, 25% less than normal. A hemoglobin reading of approximately 75%. 2. Relatively high as compared with the number of red cells. This condition occurs in all anemias of the pernicious type, e.g., a red cell count of 2,000,000, a loss of almost 60% of red cells, and a hemoglobin reading of approximately 55%. In order to be in proportion to the red cell loss, the hemoglobin reading should be in the neighborhood of 40%. 3. Actually low and relatively low as compared to the number of red cells. This relationship occurs particularly in chlorosis, that anemia of young girls that seems to consist almost entirely in a hemoglobin deficiency, e.g., red cell count 4,000,000, hemoglobin 35%. In addition to estimating the percentage of hemoglobin and the number of red and white cells, a differential white cell count is often done in order to determine whether there is any change in the percentage of the various types of leukocytes, as such changes are often of aid in diagnosis. No attempt will be made to dwell upon results obtained from differential white cell counts, as the nurse is in no wise concerned with them. End of chapter 31. Chapter 32 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 32. Pernicious Anemia and Leukemia. Pernicious anemia is, quote, a chronic and usually fatal disease of unknown origin, producing, especially in elderly men, paroxysms of intense anemia and usually degeneration of the spinal cord. Unquote. Cabot. The cause of pernicious anemia is as yet unknown. Many factors have been suggested, and some authorities believe it to be the result of an infection resembling in a way syphilis. This theory is based upon the following factors: 1. Fever occurring in pernicious anemia. 2. Enlargement of the spleen. 3. Frequency with which the spinal cord is attacked. 4. Beneficial effects of arsenic, and especially of salvarsan, given in a manner similar to that employed when treating syphilis. The pathology of the disease is complicated and obscure, and will not be dealt with. The disease is not uncommon, affects mainly individuals between 40 and 60 years of age, and is found in men twice as frequently as in women. Symptoms. A characteristic of pernicious anemia is its insidious onset. General weakness is complained of in every case. The early cases are extremely difficult to recognize, but when the condition is moderately advanced, the patient's color is very suggestive. A yellowish pallor is present, the patient having a dead, waxy tinge, different from that seen in other forms of anemia. It is a color that must be seen to be appreciated. No amount of description can do it full justice. In connection with general weakness, the patient also complains of other symptoms, some of which are characteristic of any severe anemia, others of which point more or less directly to the pernicious type. Those symptoms present in any severe anemia are dyspnea, palpitation, headache, vertigo, and, less frequently, edema. Those symptoms more or less characteristic of pernicious anemia are: 1. Gastrointestinal attacks or crises, paroxysms of severe abdominal pain, practically uninfluenced by treatment, passing off at the end of a variable length of time and often followed by a period of improvement. 2. Diarrhea, continuous or paroxysmal. 3. Symptoms suggestive of tabes dorsalis, locomotor ataxia, QV. Usually there is but slight loss of weight as compared with the general weakness. The most characteristic symptoms of pernicious anemia are to be found in the blood. The total quantity of blood is lessened. Blood pressure is extremely low. On pricking the finger, the drop of blood may look quite red, but its watery condition is at once apparent. The red cells are usually found to be below 2,000,000 to the cubic millimeter, normal being from 4.5 million to 5 million. The hemoglobin may be 50% of normal, while the red cells may be but 40 or 30% of normal. This condition is characteristic of pernicious anemia and is the result of nature's effort, in view of the very great destruction of red cells, to supply each remaining cell with as great a percentage of hemoglobin as possible. In addition, it may merely be mentioned in passing that the outlines of the red cells are irregular instead of being smooth and round, that the average size of the red cells is increased due to young, immature forms being cast into the circulation to make up for the loss in cells, and that red cells containing nuclei are found. The course of the disease is characterized by periods of marked improvement followed by periods of increase in all symptoms. The blood picture varies with the general symptoms, sometimes improving to a remarkable degree, only to grow worse again. The outlook for permanent recovery is bad, but if the patient reacts satisfactorily to treatment, life may be maintained for several years. The blood picture rarely, if ever, reaches normal, but periods of improvement may last from 3 months to 2 years. Treatment. Rest in bed for a time. Fresh air, food in abundance are, of course, indicated. The general management is very similar to that employed in pulmonary tuberculosis, QV. Arsenic is the one drug that seems to exert a favorable effect on the course of the disease. Most physicians have their favorite preparations and mode of administration. The 3 following preparations have found the most favor. 1. Fowler's solution by mouth. 2. Cacodylate of sodium hypodermically. 3. Salvarsan or neosalvarsan intravenously. Attention should also be directed toward the intestinal tract with a view to keeping it as clean as possible by means of colon lavage and intestinal antiseptics. Leukemia. This is a disease of one of the blood-forming organs, especially the bone marrow. Nothing is known as to its causation. The condition is rare. There are two main classes: 1. Myeloid; 2. Lymphoid. 1. Myeloid symptoms. 1. Enlarged spleen, usually reaches the navel, may extend into the pelvis. 2. Dyspnea. 3. Intestinal disturbances due to pressure from enlarged spleen and to dragging of the spleen on its ligaments. 4. General loss of strength. 5. Blood picture. Leukocytes enormously increased in numbers, usually 300,000 to 1,500,000 per cubic millimeter, normal 4,000 to 7,000. Abnormal forms known as myelocytes present in large numbers. Moderate anemia. 2. Lymphoid symptoms. May be acute and begin with weakness, fever, and hemorrhages from various portions of the body. May be glandular enlargement. Dyspnea. Spleen enlarged, less so than in myeloid form, but almost always present. Blood picture. Leukocytes markedly increased, averaging about 180,000 per cubic millimeter and consisting practically entirely of lymphocytes. Course. These two forms of leukemia are generally chronic from the start, and usually end fatally, though, as in the case of pernicious anemia, there are frequently extended periods of improvement. Treatment. X-ray treatment at the hands of an experienced operator has given the best results. No drug exerts any appreciable effect on the course of the malady. End of chapter 32. Chapter 33 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 33. Exophthalmic Goitre, Graves' disease. Exophthalmic goitre is a disturbance of nutrition due to a disordered condition of the thyroid gland. This gland, like the adrenal glands, the ovaries, etc., furnishes to the body what is known as an internal secretion, i.e., a secretion that is not given off through a duct, but that comes off from the body of the thyroid itself and spreads about through the tissues. The nature of this secretion is not well understood, but its presence is essential to life. It is generally believed that exophthalmic goitre is due to an excessive secretion on the part of the thyroid gland, the evidence for this belief resting mainly on two facts. 1. The conditions of myxedema and cretinism, which are positively known to be due to insufficient thyroid secretion, present a picture which is diametrically opposed to that found in exophthalmic goitre. 2. Cases of exophthalmic goitre are almost invariably made worse by the administration of thyroid extract, which contains the active principle of the secretion of that gland. Exophthalmic goitre is not a rare condition, and is assuredly met with, especially in its milder forms, more frequently than is generally believed to be the case. The earlier forms are so like mild cases of neurasthenia that this diagnosis is more frequently made. Women are more frequently affected than men, in the proportion of 8 to 1. The disease is one of early and middle adult life, occurring usually between the ages of 16 and 40. As predisposing causes are mentioned emotional shocks and worry, though it is probable that in these cases the disease was latent and that its symptoms began to show themselves after bodily, and especially nervous, resistance had become lowered. The actual cause of the disease is unknown. Symptoms. There are 5 characteristic symptoms of exophthalmic goitre. 1. Goitre. 2. Exophthalmos, bulging of the eyeballs. 3. Tachycardia, rapid heart action. 4. Tremor. 5. Nervousness. The onset of the disease is very gradual, the patient usually complaining for some weeks or months of increasing nervousness, palpitation, shortness of breath, and inability to perform ordinary duties without undue fatigue. In a well developed typical case, the neck is prominent from the swelling of the thyroid gland, the eyes are staring and bulge perceptibly, the heart action is rapid, from 120 to 150 per minute. There is palpitation, accompanied often by a choking sensation, and slight exertion brings on marked shortness of breath. When the hands are held out and the fingers spread apart as far as possible, a very fine tremor is observed in them, and, as a rule, the hands sweat profusely. There is intense nervousness. The patient starts at the slightest sound. There is inability to concentrate the attention on anything for any length of time, and the patient's spirits are poor. The appetite is bad, the tongue is coated, and constipation is frequent. There is almost always marked loss of weight and insomnia. At times there is a low grade of fever, but this is not a prominent symptom, save in the most severe cases. Some of the classical symptoms of exophthalmic goitre are very often absent, notably that of goitre. The protrusion of the eyes may be extremely slight, but cases are on record in which it has been so marked that the eyes could not be closed and eventually the eyeballs slowed away. Tachycardia, tremor, nervousness, with slightly staring eyes are the symptoms most commonly noted. Prognosis. It has been said that exophthalmic goitre is a "a disease from which patients never recover and never die." This is hardly true. It is better to say that few recover and some die. Recovery in the fullest sense of the word is not frequent, the best results usually being the restoration of the patient to a condition which enables her to lead a happy and useful life, but one during which she must be ever careful not to overdo, and during which she must take longer or shorter periods of rest in order to tide over the times when the thyroid again begins secreting too actively. Treatment. As far as the general management is concerned, a routine is indicated which strongly resembles that advocated for cases of early pulmonary tuberculosis. For details, see chapter on tuberculosis, consisting in rest in the open air and abundant, nutritious, and easily digestible food. Nervousness is generally best dealt with by means of continued rest, warm baths at night, and the administration of full doses of the bromides when necessary. It is not considered good practice to give morphia or any of the preparations of opium to these patients. Iodine is a drug that sometimes helps these patients and sometimes seems to make the condition worse. When used, it is usually given in the form of potassium iodide and the syrup of the iodide of iron. Iron in some form is often given, as there is usually a moderate degree of anemia. The use of extracts of the thymus gland and the use of thyroidectin, which is a substance made from the blood of sheep, whose thyroid glands have been removed, have benefited some cases, while in the majority of instances they have failed. Surgical treatment. Surgery has been of greater benefit to cases of exophthalmic goitre than has medical treatment. Two main surgical procedures are in use. 1. Resection of a portion of the gland, usually not over 2/3. 2. Ligation of 2 or 3 of the 4 thyroid arteries, in the hope of lessening the activity of the gland by limiting its blood supply. Probably the best treatment for a case of exophthalmic goitre is surgery in the hands of an expert, together with careful previous and subsequent general management on the part of the general practitioner. End of chapter 33. Chapter 34 of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Perard. Chapter 34. Immunity. Immunity is defined as exemption from disease, or that condition of the body which enables it to resist infection. Immunity and infection, though opposites, are so intertwined that mention cannot be made of one without reference to the other. Immunity can be classified as follows. 1. Natural immunity. Thus, the human race is naturally immune to chicken cholera, and animals are naturally immune to measles. 2. Acquired immunity. Thus, one attack of typhoid fever usually renders an individual immune to that disease. A certain amount of immunity may be acquired toward a particular disease by its frequent occurrence. When syphilis first appeared among Europeans, its ravages were frightful, but within 50 years, as a result of the countless number of cases that appeared, individuals developed a relative immunity to the disease, and as a result its manifestations were not as terrible. When an individual is attacked by an infection, the defensive resources, or immunizing forces, of the body are called upon to do their part in repelling the invader. The stronghold of the defensive resources of the body is the blood. Certain cells of the blood play an active part in resisting infection, and many substances present in the blood serum play their part in safeguarding the organism. Phagocytosis. By this is meant the power of the white blood cells to ingest, kill, and digest bacteria. Elie Metchnikoff of Paris is the man to whom science owes an unpayable debt for his labor in demonstrating the act and consequences of phagocytosis. It is known that the leukocytes are capable of motion by projecting a portion of their body in the shape of a long, finger-like process. The rest of the body of the leukocyte is then drawn up to the finger-like projection, and thus the leukocyte moves. This is known as amoeboid movement. When an infection exists, leukocytes at once come to the battleground, and a struggle ensues between them on the one hand and the bacteria on the other. The leukocytes, by their power of amoeboid movement, surround one or more bacteria, engulf them, and digest them. This can be observed under the microscope, the bacteria being seen to be engulfed, to grow less and less distinct within the body of the leukocyte, and finally to become wholly invisible. If the infection is not of excessive virulence, and if the leukocytes are healthy and plentiful, the body wins the fight against the bacteria, and recovery ensues. This is why it is always a good sign in an acute infection, such as lobar pneumonia or appendicitis, to have the blood show a high leukocyte count. If, however, the infection is very virulent and the body defenses inadequate, no leukocytosis results and death ensues. Metchnikoff has shown that acquired immunity is largely due to stimulated phagocytosis. This is true whether the immunity is due to one attack of the disease or to vaccination. A rabbit which has been artificially immunized to anthrax shows a more marked phagocytosis on inoculation with a virulent culture than does a rabbit that has not been artificially immunized. In the blood serum are found many substances that play a role in the production of immunity. Among these may be mentioned: 1. Precipitants. 2. Agglutinins, substances that cause bacteria to clump and upon whose presence is based the vital reaction, so valuable in the diagnosis of typhoid fever. 2. Opsonins, substances that, as it were, prepare and make ready bacteria so that they can more readily be engulfed by the leukocytes in the process of phagocytosis. The theories of the mechanism of immunity are extremely complex, and no attempt will be made to describe them here. Paul Ehrlich of Berlin has elaborated the chief among them, his famous side chain theory of immunity, which in brief is as follows: a cell possesses normally certain defensive forces or receptors, which will unite with a certain amount of toxin and neutralize it, thus protecting the cell. When a cell is threatened with attack by a toxin, it is stimulated to the production of other receptors, or side chains, and immunity comes about when there is such an overproduction of these side chains that there are more than enough to neutralize every bit of toxin that is attacking. Acquired immunity may be: 1. Active; 2. Passive. In specific treatment of various infections, it is sought in some cases to produce an active immunity, in others a passive immunity. By an active immunity is meant that the body, stimulated by the infecting bacteria or by the injection of those same bacteria killed, i.e., a vaccine, manufactures its own resisting forces, brings up its own reserves, and actively fights its own battle. Vaccination against typhoid fever is a good example of the production of an active immunity, for, as a result of the injection of a certain number of killed typhoid bacilli, the body is stimulated to such an overproduction of receptors for typhoid toxin that it can resist infection with live typhoid bacilli and not become ill with the disease. By passive immunity is meant that the body is supplied from outside with its means of defense ready to use and requiring no effort at all on the part of the individual. The best example of the production of a passive immunity is to be found in the antitoxin treatment of diphtheria. Here, a certain amount of antitoxin secured from another artificially immunized animal, the horse, is injected, and at once is able to neutralize the diphtheria toxin circulating in the patient's blood. This neutralization goes on with no effort whatsoever on the part of the patient, whose role is merely passive. This form of immunity can be used with success only in those diseases that are purely toxic, i.e., in which the infecting bacteria themselves do practically no harm, but only the poisons liberated by those bacteria. Hence, the use of antitoxic sera, while giving brilliant results in purely toxic diseases such as diphtheria and tetanus, have unfortunately but a very limited range of application. To quote Vaughan, "Now we have the great problem of infection and immunity fairly before us. It is a contest between bacteria and body cells, and they are armed with similar weapons. The bacterial cells have their enzymes, poisons, and toxins. The body cells have their enzymes, bactericidal, bacteriolytic agents, opsonins, and phagocytes. The phagocytes constitute the mobile army of defense, and the fixed cells elaborate destructive weapons. Which of these bears the brunt of the defense depends upon the armament of the invader." Unquote. If the invasion is mainly bacterial in its nature, the leukocytes are called upon to play the principal part in winning the victory. If the invasion is mainly toxic, the tissue cells have to bear the brunt of the defense. If the invasion is both bacterial and toxic, all the arms of the service play an equally important part in saving the body from destruction. End of chapter 34. Glossary of Clinical Medicine for Nurses by Paul H. Ringer, A.B., M.D. This LibriVox recording is in the public domain. Reading by Matt Berard. Glossary. Aeration. The state or process of being supplied with air or gas. Agglutinin. A specific principle occurring in the blood serum of an animal affected with a disease microbic origin and capable of causing the clumping of the bacteria peculiar to that disease. Albuminuria. The presence of albumin in the urine. Alveolus. An air cell of the lung. Ambulant. Referring to a patient that is up and about, not confined to bed. Anemia. Deficiency of blood as a whole, or deficiency of the number of red corpuscles, or of the hemoglobin. Anasarca. An accumulation of serum in the subcutaneous areolar tissues of the body. Anesthetic. Any drug that causes insensibility to pain. Anorexia. Loss of appetite. Antitoxin. A counterpoison or antidote manufactured by the body to counteract the toxins of bacteria. Anuria. Absence of secretion of urine. Aorta. The main arterial trunk of the body arising from the left ventricle of the heart. Aphasia. Partial or complete loss of the power of expressing ideas by means of speech or writing. Aphonia. Loss of the voice. Apoplexy. Hemorrhage from a blood vessel in the brain. Arteriosclerosis. A chronic inflammation of the arterial walls resulting in more or less extensive fibrous tissue formation. Ascites. Fluid in the peritoneal cavity. Auricle. One of the two upper and smaller chambers of the heart. Bactericidal. Having the power of killing bacteria. Bacteriolytic. Possessing a disintegrating action upon living bacteria. Basophile. A leukocyte whose granules stain with basic dyes. Bronchitis. Inflammation or catarrh of the bronchial tubes. Buttock. The fleshy part of the body back of the hip joint formed by the masses of the glutei muscles. Calorie. The amount of heat required to raise a kilogram of water 1 degree centigrade. Capillary. A minute blood vessel connecting the smallest branches of the arteries with those of the veins. Carbohydrate. An organic substance containing 6 carbon atoms, or some multiple of 6, and hydrogen and oxygen in the proportion in which they form water, H2O. That is, twice as many hydrogen as oxygen atoms, C4H10O5. Carbon dioxide. A gas chemically known as CO2 or carbonic acid gas. Cardiac. Relating or pertaining to the heart. Catharsis. Purgation. Chlorosis, a form of anemia most common in young women, characterized by a marked reduction of hemoglobin in the blood, with but slight diminution of red corpuscles. Cordae tendineae, the tendinous strings connecting the papillary muscles of the heart with the mitral and tricuspid valves. Chorea, a functional nervous disorder, usually occurring in youth, characterized by irregular and involuntary action of the muscles of the extremities, face, etc., with general muscular weakness. Synonym: St. Vitus' dance. Cicatrization, scar formation. Clinical, relating to bedside treatment. Coma, unconsciousness from which the patient cannot be aroused by external stimulus. Compensation, the extra work performed by a leaking heart in order to maintain the balance of the circulation. Crisis, the sudden termination of a fever. Cusp, a flap of a heart valve. Cyanosis, a bluish discoloration of the skin from deficient oxidation of the blood. Cyanotic, referring to an individual exhibiting cyanosis. Cystitis, inflammation of the urinary bladder. Delirium, a condition of mental excitement with confusion and usually hallucinations and delusions. Deoxygenated, deprived of oxygen. Desquamation, a shedding of the superficial epithelium of the skin, peeling. Detritus, unrecognizable or formless waste matter. Diaphoresis, sweating. Diaphragm, the muscular and tendinous plane separating the thorax from the abdomen. Diastole, the period of rest in the cardiac cycle. Dicrotic, the term applied to a pulse beat in which with every wave the examining finger feels a double beat. Diffusible, spreading to all parts of the body. Diplococcus, the coccus or round germ occurring in pairs. Diuretic, any drug that increases the flow of urine. Dysphagia, painful swallowing. Dyspnea, shortness of breath. Edema, presence of serum in the subcutaneous tissues. Embolus, a particle of fibrin or other material brought by the blood current and forming an obstruction at its place of lodgment. Empyema, pus in the pleural cavity. Endocarditis, inflammation of the endocardium. Endocardium, the lining membrane of the heart. Engorgement, congestion. Enzyme, a digestive ferment. Eosinophile, a leukocyte whose granules stain with acid dyes. Epidemic, a term applied to a disease affecting a large number or spreading over a wide area. Epiglottis, a cartilaginous structure situated behind the root of the tongue that prevents food and drink from passing into the larynx. Epithelium, a term applied to the group of cells that covers the skin and that lines all canals having communication with the external air, as the mouth, urethra, intestine, etc., and that are specialized for secretion in certain glands, as the liver, kidney, etc. Erosion, eating away. Eruption, a rash. Erythrocyte, a red blood corpuscle. Exophthalmic, relating to exophthalmos. Exophthalmos, protrusion of the eyeballs. Exudate, the material that has passed through the walls of blood vessels into adjacent tissues. Febrile, having fever. Feces, the movements of the bowel. Fibrin, a proteid found in blood after it has been shed, and constituting the main factor in the clotting of blood. Fibrosis, formation of fibrous tissue. Flagellated, bearing hair-like processes or flagellae. Focus, the location of an infection. Fomites, any substance that absorbs and transmits a contagion. Gastric, relating or pertaining to the stomach. General anasarca, serum in the tissues and in the peritoneal and pleural cavities. Germicide, any substance having the power of killing germs. Glomerulus, one of the secreting elements in the kidneys, lying in the cortex of that organ and formed of a tuft of capillaries surrounded by a capsule, Bowman's, and giving off a uriniferous tubule. Goitre, a swelling of the thyroid gland not of inflammatory origin. Gout, a disease of metabolism characterized by attacks of pain in the small joints, and by a deposit therein of sodium urate. Hemophiliac, an individual in whose blood the power of clotting is reduced or absent, a bleeder. Hemoglobin, the coloring matter of the blood, found in the red blood corpuscles. Hemorrhagic, pertaining to hemorrhage, bloody. Hepatization, the name applied to the second and third stages in the consolidation of the lung in lobar pneumonia. Herpes, an acute inflammatory condition of the skin characterized by the development of a group of vesicles. Herpes zoster, an eruption occurring along the course of the intercostal nerves. Synonym: shingles. Hydrocephalus, a collection of fluid within the ventricles of the brain, or outside the brain, between it and the skull. Hydrotherapy, treatment by means of water. Hydrothorax, fluid in the pleural cavity. Hyperemia, congestion. Hyperplasia, excessive formation of tissue, an increase in the size of a tissue or organ owing to an increase in the number of cells. Hypertrophy, an increase in the size of a tissue or organ independent of the general growth of the body. Hyperpyrexia, excessively high fever, over 106 degrees Fahrenheit. Hypertension, blood pressure that is above normal. Hypnotic, any drug that produces sleep. Hypochondrium, the upper lateral region of the abdomen beneath the lower ribs. Hypodermoclysis, the subcutaneous injection of fluid. Hypotension, blood pressure that is below normal. Incontinence, lack of control over the contents of either bladder or rectum. Incubation, the period of a disease between the onset of the infection and the development of symptoms. Infection. 1. The communication of disease from one body to another. 2. The agent that produces disease. Infectious, having the power of communicating disease. Infusion, the intravenous injection of salt solution. Ileum, the third portion of the small intestine. Immunity, the condition of the body in which it resists the development of disease. Inhibitory, checking, restraining. Inoculation, the act of introducing the virus of a disease into the body. Insomnia, inability to sleep. Intercostal, relating to any structure situated between the ribs. Interstitial, pertaining to interstitial or connective tissue. Intracranial, situated within the skull. Invasion, the onset of a disease. Jejunum, the second portion of the small intestine. Koplik's spots, small bluish spots seen in cases of measles and occurring on the mucous membrane of the cheeks and lips before the appearance of the rash, an absolutely diagnostic sign of measles. Laryngitis, inflammation of the larynx. Leukocyte, a white blood corpuscle. Leukocytosis, an increase in the number of leukocytes. Ligation, the tying of a blood vessel. Lumen, the cavity surrounded by the walls of a tubular vessel. Lymphocyte, a variety of leukocyte having a very large nucleus and a relatively small cell body. Lysis, the gradual disappearance of a fever. Macule, a spot upon the skin not elevated above the surrounding level. Malaise, a general feeling of illness accompanied by restlessness and discomfort. Media, the metal coat of the wall of an artery. Megaloblast, a large nucleated red blood corpuscle. Meninges, the dura mater, pia mater, and arachnoid membranes of the brain and spinal cord. Metabolism, the group of phenomena whereby organic beings transform foodstuffs into complex tissue elements and convert complex substances into simple ones in the production of heat and energy. Metastatic, referring to metastasis, which is the transfer of a disease process from one part of the body to another by means of the blood or lymph channels. Meteorism, gas in the intestines. Motile, possessing the power of motion. Mucoid, resembling mucus. Myocarditis, inflammation of the heart muscle. Myxedema, a disease of nutrition due to lack of secretion or absence of the thyroid gland. Necrosis, death of tissue. Necrotic, referring to necrosis. Nephritis, inflammation of the kidneys. Neutrophil, a leukocyte whose granules stain with neutral dyes. Normoblast, a red blood corpuscle of normal size having a nucleus. Nucleated, possessing a nucleus. Nucleus, the essential part of a typical cell. Oliguria, a deficient amount of urine. Opsonin, a substance in blood serum that prepares bacteria for digestion by leukocytes. Organic, pertaining to the animal and vegetable world. Otitis, inflammation of the ear. Oxidation, the act or process of combining with oxygen. Oxygen, a colorless, tasteless, odorless gas, composing 1/5 of atmospheric air, and in the absence of which human and animal life cannot be maintained. Palpitation, consciousness of the heartbeat. Papule, a small circumscribed solid elevation of the skin. Paracentesis, puncture of the wall of one of the cavities of the body, e.g., the ear, the pleura, the peritoneum. Parasite, an animal or vegetable living upon or within another individual. The host, e.g., malarial parasite in red blood corpuscles, tapeworms in intestines. Parenchymatous, referring to the parenchyma or specialized portion of an organ, as differentiated from the supporting and surrounding tissue. Pathogenic, producing disease. Pathological, referring to pathology, which is that branch of medical science that treats of the modifications of function and changes in structure caused by disease. Pericarditis, inflammation of the pericardium. Pericardium, the membrane covering the heart and the root of the aorta and pulmonary artery. Peritoneum, the membrane lining the interior of the abdominal cavity and surrounding the contained viscera or organs. Peritonitis, inflammation of the peritoneum. Phagocytosis, the process of ingestion and digestion of microorganisms by the leukocytes. Phlebitis, inflammation of a vein. Physiology, the science of the normal workings of the human body. Pitting, the formation of a pit or hollow by pressure upon edematous subcutaneous tissue. Pleura, the membrane surrounding the lung. Pleurisy, inflammation of the pleura. Pneumococcus, the causative factor in lobar pneumonia. Pneumonia, inflammation of the lung. Pneumothorax, air in the pleural cavity. Poikilocytosis, irregularity in outline of red blood corpuscles. Polymorphonuclear, a leukocyte having nuclei of varied shapes and sizes. Polyuria, an excessive amount of urine. Precipitin, a substance present in blood serum capable of producing a precipitate in a clear solution of the particular albumin or culture filtrate against which the individual whose blood is used has been immunized. Prophylactic, preventive. Proteid, any of the important and essential nitrogenous constituents of animal and vegetable tissues. Ptosis, a drooping or sagging, may refer to drooping of the eyelid or to a general sagging down of the abdominal viscera. Purulent, containing pus. Pus, a liquid substance consisting of cells and an albuminous fluid formed in certain kinds of inflammation. Pyemia, a disease due to the presence in the blood of pus-forming germs. Pyelonephritis, inflammation of the kidney and its pelvis. Receptor, one of the so-called side arms of a cell, which, according to Ehrlich's side chain theory of immunity, is for protection of the cell by uniting with an attacking molecule of toxin. Regurgitation, the backflow of blood through a heart valve that is defective. Remission, a fall in fever in which, however, the temperature still remains above normal. Resection, the process of cutting out and removing. Resolution, the fourth stage in the evolution of the process undergone by the inflamed lung in lobar pneumonia. Sedative, a drug whose action is to quiet the patient. Semilunar, the valves guarding the openings of the aorta and pulmonary artery. Sepsis, blood poisoning. Septicemia, blood poisoning. Seros, relating to serum. Serum, the clear yellow fluid that separates itself from the clot after the shedding of blood. Swords, the crusts that accumulate on the teeth and lips in continued fevers. Splanchnic, pertaining to or supplying the viscera. Sputum, the secretion of the lungs and bronchi. Stenosis, constriction of a heart valve, as a result of which it cannot open as fully as it should. Stippling, a term used to describe a peculiar spotted appearance of red blood corpuscles in severe anemias. Striated, possessing striae or stripe-like lines. Stupor, a cloth used for applying heat or counter irritation. Stupor, a state of partial unconsciousness from which the victim can be roused. Systole, the period of contraction or work period of the heart. Tachycardia, excessively rapid heart action. Thrombosis, the formation of a thrombus. Thrombus, a clot of blood formed within the heart or blood vessels. Toxemia, blood poisoning, a condition in which the blood contains poisonous products, either those produced by the body cells or those due to the growth of microorganisms. Toxin, a poison. Tracheotomy, the operation of opening the trachea or windpipe and inserting a tube through which the patient can breathe. Tremor, a trembling of the voluntary muscles. Tubercle, the specific lesion produced by the tubercle bacillus. Vagus, the 10th pair of cranial nerves. Vascular, pertaining or relating to the circulatory system. Vasodilator, a drug causing dilation of the arteries and consequent lowering of blood pressure. Venesection, the operation of opening a vein in order to allow the escape of a certain amount of blood, bleeding. Ventricle. 1. One of the two lower larger chambers of the heart. 2. One of several spaces in the brain. Virulent, having the nature of a poison. Vomitous, the material that is vomited. End of Glossary. End of Clinical Medicine for Nurses by Paul H. Ringer, AB, MD.